And I'm going to send it to Alan after. All right. Welcome, everybody. This is a cross promo video with the Institute of Clinical Excellence in Geros Health. My name is Christina Previtt. Oh my gosh, my last name. I am lead faculty for Modern Management of the Older Adult, Essential Foundations and Advanced Concepts. I am also one of the podcast contributors to Geros, and I have been in the Geros community for over 5 years now. Oh my goodness. I'm being joined today by Julie Brower. She is an acute care physical therapist down in North Carolina. And we thought that we would just have a conversation today about what is happening with COVID-19. There's a lot of questions. There's a lot of concern about some of the different statements. I am a private practice owner up in Kingston, Ontario, Canada. And so we can talk a little bit about essential and non-essential PT, because I think there's been a lot of gray area there. Jeff made an amazing podcast kind of talking a little bit about that. And then we've heard some opinion pieces from emergency room physicians talking about their perspective around what is happening as more and more cases accumulate with COVID. But I thought it'd be really great to get the PT perspective about some of the things that we are starting to see. So welcome, Julie. Thank you so much for joining me today. And I thought the first thing that we can do is get a little bit of a background on you and go from there.
Yeah, so I have been working in Charlotte, North Carolina as a PT since November of 2015. So I've been primarily in acute care at a level 1 trauma center. And then in addition to that, my brother also owns a fitness facility down here. So I frequently work with an athletic population as well. But most of my time is in acute care. I was 2 years full-time there, and then I transitioned into a role to where it's called float pool. So basically I cover acute care, all of many of the hospital sites, and then also inpatient rehab. Awesome. So that's kind of what I've been doing for the past, I guess now almost 5 years, which is crazy.
Yeah, amazing. And you are somebody who loves being in acute care and working in geriatrics, which is one of the things we love about you, especially the modern management faculty, because it's nice to see your enthusiasm for working in this role, which is really cool.
Yes, I love it. I love it.
So why don't you tell me a little bit about the current situation with COVID in your area?
Yeah, so right now, one thing that's surprising a lot of people when they ask is, are you super busy? Are things crazy right now? And the answer is actually no. The hospitals have cleared out because they have canceled all elective surgeries, so joints and back surgeries, which a lot of time can account for almost 40% of our caseload. So it's very, very quiet. The volumes are low from a PT standpoint. But like we were just saying, volumes are very low, but this kind of fear and panic is starting to rise and rise and rise. There's actually, Christina, you would probably really like it. There's actually an article I read about like a pre-traumatic stress disorder about what's about to happen. So we're all just kind of buckling down and really trying to just figure out what the plan is and what I think is kind of consistent among a lot of the people within Geros in the acute care facilities is that there's no consistent plan. Policies and procedures and plans are changing day to day, even hour to hour, and it has been a headache to try and figure out what the standard of care is, what the precautions are, what to do, what not to do when it's very, very frustrating. Trying to get just what do I do and how do I stay safe and how do I keep my patients safe, and getting those answers is very, very difficult.
Yeah, I know there's a lot of clinicians, especially in the geriatric space, where the way that this virus spreads is what is making people nervous, because oftentimes it's when individuals are asymptomatic and they don't know that they're carrying COVID, that's when they are transmitting it to other people. And so clinicians, I think, are not only just concerned about protocol for themselves, so they're not getting COVID, but I've also talked to a lot of clinicians who are afraid that they're going to be the vector. Like they feel like it would weigh on their conscience if they ended up developing COVID in 3 days because of an exposure from another client and then they've just exposed their whole caseload who are vulnerable or frail or homebound to something that could potentially be catastrophic for those individuals who are super vulnerable. Has that been addressed by your leadership?
Oh, and it depends on the hour of the day. what it looks like. It's hard because with testing, so even if you have been exposed, even if you think that you've been exposed to someone who has it, they're not really doing testing unless you are symptomatic. And even literally probably right before we got on this call, we got an email that even if you're symptomatic, like you can still go to work. And so, and again, these things are just rolling in by the hour of policies that are changing. And so it's hard because you know that you may be around someone who's exposed, but you're not going to know because they're trying to conserve doing the testing. So that person may not even be tested. So you don't have a great way to even know what level of risk you're at or that you're putting your other patients at.
Yeah, I know in Ontario, where I'm getting a lot of my information from, even the diagnostic or the criteria rather that they're using to decide who is getting tested and who isn't is also constantly changing, because it used to have to be that a person was symptomatic and had recently traveled. But now what we're seeing across the US and Canada is that the community spread, where we can't find the original link from a person who had traveled, is just growing exponentially, unfortunately. And that's leading to a lot of questions about, okay, so then how do we decide who is tested?
Exactly.
And then on the flip side, it's almost becoming that the assumption is that everybody is positive.
Right.
Can you kind of comment on that?
Yeah. So I mean, it comes around, it almost is like this weird circle. So, you know, you're going to get tested if you have those, like those cardinal symptoms, those respiratory symptoms, fever of over 100.4, cough, things like that. But then also if you've been exposed to a known person who is tested positive. But again, that creates this vicious circle because everyone's not getting tested. So you don't know whether you have been exposed to someone who's positive. So and they're telling us the same thing. The safest thing to do is to assume that you could be a carrier and to act as if, you know, to have that level of caution with everything you do as if you are an asymptomatic carrier.
Right. And then, so the question that, or the problem potentially that comes with that is PPE.
Yeah. So I literally, between sending emails to like our director of rehabilitation, so I've sent her multiple novel-sized emails of questions, and then digging into what our hospital system is saying, and then actually like looking at what the CDC is actually saying, right? So when you boil it all down, the CDC is saying, if you are going to be in contact with a patient who is positive for COVID-19, you should be wearing, you know, all the typical PPE plus an N95 mask or a respirator. So partial face shield that, you know, is supposed to be able to filter out those infectious particles. Per our hospital system, they're telling us to only wear a surgical mask, gown, gloves, eye protection. And then if you kind of dig even a little bit deeper, there's even separate guidelines if you're in the ICU or if you're in the ED. And then it becomes, if you're going to be providing respiratory treatments, what type of PPE are you going to be wearing? So it is, I mean, it is so confusing when you put that all together. And come back to the CDC is telling us N95 masks. That is what it is. That's what the standard should be. That is the recommendations to for PPE, and everything beyond that is it's changing from our hospital system standpoint, day to day, hour to hour.
Right. And do you think those changes are coming largely because of the shortages in things like N95s? And so they're trying to figure out ways to still protect healthcare providers, because we're starting to see healthcare providers testing positive for COVID despite trying to do their best in regards to protecting themselves.
Exactly.
But we're still facing this massive shortage. Just before we got on this call, Julie was talking about hearing the governor from New York, which is definitely, as of the time of this meeting, a big hotspot in the US.
Yep.
And they are in such desperate need for things like ventilators and shields.
He literally was saying, like, we were given 400 ventilators and we need 30,000. I mean, and that's terrifying, because you hear these stories of how do you decide, and I know that from the ER doctor that Jaro's posted, which person are you triaging who needs the ventilator? And the idea from the governor of New York was, we are the apex. New York, it's hitting New York the worst first. Give us the ventilators, and then after we come to decline, then disperse them throughout the other areas that is going to be the next apex.
Yeah.
And it just on a day-to-day, very small scale. I mean, it's sad. My coworkers saw families and other staff just hoarding and stealing masks. Masks are now on like lock and key. So when I work, I got to go up and I have to ask for a mask to wear.
Yeah.
And then, and people are, handing them out without sanitizing their hands or putting gloves on. And so it's so unfortunate. And I know that there's such a shortage and we're trying to conserve as much as possible. But even then you think, okay, well then, can I rewear this? Does this have to be disposed? How do I clean this, right? So now I know, like, nurses are wearing one surgical mask. If they're staying on the same unit, they're keeping it on for their entire shift.
Yeah, for sure. And it's just kind of trying to make the best sometimes of what we have. I was speaking in Kingston to a nurse who does education on PPE, and she was saying it is such a nightmare right now because, again, the guidelines are changing. Like she's saying, with the shortage, if you have a physician that is standing at the front of the room who couldn't possibly be within 6 feet of the person's face, and there's a nurse who's by the bedside doing things like switches, then the positioning, right, then the nurse should have priority over the equipment. And that's a decision that has to be made. But the College of Physicians and Surgeons is saying absolutely not. So now it's almost, in some cases, going to potentially create conflict between other healthcare providers. Or like if you have a PT and an OT in the room and the PT is by the bedside and the OT is at the front of the room, like, does the PT get a mask and the OT doesn't? Do you just have one person go in even though both healthcare providers are warranted? Like, these are the types of conversations that I think are going to come up. And the more and more, I guess, we are socially distancing, the less and less you guys on the front line are going to be affected by that.
Yeah. And I mean, I just heard from my best friend who owns a clinic in Maryland. He just had to get tested for it. I mean, there are, internal medicine residents at the hospital who are all in quarantine right now. And so our staff, our healthcare providers who are on the front lines already are getting sick.
Yeah.
And so I think that's why they just put out this new, kind of this new statement about still basically coming to work and just monitoring it, to doing temperature checks. And so even if you've been exposed, it's like, come to work and do temperature checks until you start developing like those respiratory symptoms and then be removed. So those guidelines are even becoming less strict too, which is just scary, because then you just look at more risk of exposure as a whole.
Yeah. And so from my perspective up here in Canada, the College of Physiotherapists of Ontario, which is our regulatory body, has actually been extremely direct and has pretty much, they said they can't legally, without being the Ontario government, force us to close, but they have mandated all outpatient private practices, even though like we don't have that many cases in Kingston. We probably have about 10 or 12 at this time. That's going to probably change, obviously. And they talk about the difference between essential and non-essential. And I think that it's been extremely helpful as a private practice owner because it's so stressful when you're financially at risk. But just like you say, if the standard from the CDC is full PPE, are you going to be doing that in outpatient practice? And the odds are probably not. And you can have somebody who's an asymptomatic carrier. So in the last 8 days, the only person I saw is one person who I have been seeing intermittently who's been in and out of hospital with pericarditis every time her joints flare from an autoimmune condition. And she was having one of the worst flares she's ever had. And I was like, that to me, I was like, I'm going to try and manage her pain as much as I can because I do not want her in hospital right now. But it's like a constant mental, moral, ethical, financial battle that, but I feel like as an outpatient clinician, it directly affects you guys in the front line. And I know Dustin feels that really acutely as well because his wife, Megan, is an emergency room physician, also battling that front line in Kentucky.
Yep. And I mean, from the outpatient standpoint, you know, in Charlotte, there are a lot of clinics who are still open. There are a lot of clinics who are still open. And, you know, again, if you go back to the CDC, they very specifically say, again, this is the PPE you should be wearing. These outpatient clinics, typically these, you know, the PTs, the providers are not fit tested with the N95 mask. They don't have a respiratory program. So it does not meet those guidelines. And that's very, very clearly stated there. And so, you know, I know that some of my colleagues who are in outpatients there, business is pretty much as usual, which is terrifying. And some, you know, obviously like Jordan and Zach, like they're just, you know, right away, they're like, this is what the CDC says. This is for the safety, you know, of the general community and reducing risk. Like we're shutting our doors. And I know from like a home health standpoint, it's creating still a lot of moral battle there. And some people are getting reprimanded from their superiors. And I know some clinics are cutting salary to their, you know, to their employees. And so it's just, that's awful because it's like these people need to keep their jobs and they're desperate to keep their jobs, but now they're having their salaries cut. Yeah. And it's, I mean, I know some of my coworkers who are in outpatient, they're filing for unemployment right now.
Yeah. Yeah. And that's pretty consistent here in Kingston as well. Our prime minister just announced a huge stimulus package to try and help people who are in the same financial strain. This might be a weird thing to say, but feeling like we're all in this together actually gives me a sense of comfort. Because, you know, I'm trying as a clinic owner to be socially responsible, but it creates a lot of anxiety. I have a young daughter at home. Like I have a mortgage. I have to pay the rent on our facility. But no, like we've connected with all the other gyms and several of the clinics in Kingston and just started talking about, you know, how they're feeling. And, you know, it's like there's like these polar ideologies around it where some people are on the side of let's just let this run its course and put business as usual and just let it run its course because it's a new virus. And then there's other people who are obviously in the social distancing camp. And I feel like Canada as a whole has been very far to the social distancing side. Mm-hmm. Our prime minister has been more and more forceful around, like, I don't want to put in legal mandates to make you guys stay at home, but if you're not paying attention to these social distancing calls, and as of the time of this recording, we're at like 2,800 cases, largely in Quebec, Ontario, and British Columbia. Yeah. He's like, I'm going to have to put stricter and stricter mandates on the people here in Canada. And so it's almost like a social faux pas here in Kingston if you're not socially distancing. Yeah. People like, it sounds awful, feel like judge you. Be like, right. What do you mean you're going out and doing this? Like you should be at home, like all these types of things, which is kind of
And it's kind of the same around here. I feel like Charlotte is Charlotte's like a week behind. I compare it to Cleveland, so that's home for me. And so, my mom is recovering from cancer, so she's very, very high risk. So I've been in very close contact speaking with her, and she's telling me about how, no one is on the streets in Cleveland. Cops are going around and giving out tickets. They're checking to see where you're driving to. They're knocking on doors to make sure businesses are actually closed down. And one of my best friends is she worked at the Cleveland Clinic, and she's like, wait, like you're still going outdoors to like do things? It's the same thing. It's like, you guys, like, stop, and Charlotte just yesterday ordered like a proclamation of stay at home. So same thing, we're starting to get those more strict rules there in terms of like, only if it's essential for you to go out grocery store to help, you need to help somebody, basically caregiver, or you're going to you're going into healthcare to work, and so we're seeing that it's a little bit by a little bit. But Charlotte is, even today the streets are packed, the parks are still packed. Last week I was going on a run, and typically going along this trail where you would see some people but not many. You could not see the pathway, and so you're looking around like, oh, we're about to get grounded. Like, this is they're about to tighten it up. And
that ended up causing all of the closures of many of our parks because everything was closed. People were trying to go outside, but it was going against social distancing rules because now there's too many people in one spot, even though they're outside.
And it's hard. With especially in ICE and Jaros and our community, the people who are so fitness forward. It's rough. It's hard. And I'm the most like restless person. I cannot sit still. If I can't get out and go run, or it's huge. But again, you just have to, when you really do think about that, the only thing we can say throughout all this, and from other countries that have quarantined and you see the results, I think the social distancing and really just cutting off exposure from groups is the one thing that we can say we know works. So then do it.
Yep.
So,
and I know in Canada, I was joking about how this is kind of starting to develop into almost like a World War III. We're not fighting another country. We're fighting this virus we can't see because like everything is closed. Things like Rogue Fitness are starting to change what they are doing. Like, instead of doing fitness equipment, they're making masks and face shields. Today they announced that they were doing as well. One of the breweries in town is making hand sanitizer. And it's just amazing. Like, these things are starting to happen. And the College of Physiotherapists of Ontario essentially tried to draft us. So they sent a letter an email to every practicing physiotherapist in Ontario and said, if you have the capacity to come to frontline, if you are retired and you can come out of retirement to help us with the response to this, we want you to add yourself to this list. So essentially I could be like drafted to frontline, and I will probably be messaging you because my acute care is rusty. But of course, like, we are going to try and help with the response and reduce the burden as much as we can. And I recognize with some of the private payer systems that might not necessarily be as possible in the US, but with our public system, there's definitely been a call for more people coming to help.
And that's like, when you posted that, I was like, yes, like, that's amazing. Like, let's go. Yeah, we need everyone we can possibly get. Yeah. Because that's kind of what they're, like, our managers are communicating with us. Like, right now, again, it's this calm before the storm, but y'all, like, buckle up because it's about to get crazy. And like, ICE community and Jaros, and y'all are always saying, lead from the front, and it's like, we don't have a choice. Like, we don't have a choice anymore. We are the front lines.
Yeah.
And we have to lead.
Yeah.
Now is the time to buckle up. And honestly, we have to get very creative, especially in acute care, and really increase the breadth and depth of our skill and our knowledge. Because if you really kind of project this out, you're going to have patients who are in the hospital who are not being accepted to rehab facilities. So I know that for a fact, just from, I've had a lot of discussions with case managers and social work recently. Facilities are not letting patients in, or you have acute rehab liaisons who come into the hospital to evaluate patients who can no longer do that because of visitor restrictions. Very, very strict visitor restrictions. So you have these, and then you have families who don't want their loved ones to go to a facility because they can't visit them. So you have all of these different angles coming at you, and you have this patient who, you know, they're either going to be become a resident of the hospital for a while. They're going to be there, or it's going to be up to therapies to work incredibly hard to get these patients home safely, right? And so, but you have to expect that as acute care therapists, we may be the one provider that they're seeing. They may not get home health when they get there. Home health is going to be completely overwhelmed. Outpatient, we know, is not a feasible option, like especially if you're thinking about our older adult clients, right? So unless they do telehealth. And I mean, I literally have sat in a patient's room and I've brought up onward physical therapy. I'm like, they do telehealth. Like if like you need outpatient services, we need to make sure they can get through it with telehealth. But again, we have to assume that while they are there hospitalized, we have to kind of take on a role of home health, and we have to take on a role of outpatient to be able to give them those resources while they're in the hospital, because once they go, they could literally be isolated at home without resources. So now is the time for acute care therapists to, you know, take what we can from our colleagues in outpatient and home health and give our patients literally as much as humanly possible while they're in our care.
Totally. And I think that sense of urgency is so important, especially knowing that it's not just acute care that's going to be overloaded. It's going to be downstream as well as people start recovering from COVID, right? We're just at the beginning of it, where people are still in that active exposure phase. But as it goes into, that recovery stage, they're also going to be probably respiratory compromised, and they probably already were to begin with. So can you kind of talk about what your treatment looks like for somebody who is positive for COVID? What are you kind of doing with them?
So we, as of today, right? So therapy has not treated any positive cases. So across our hospital sites, we do have, we have several positives. We have a few that are in the ICU who are intubated right now. That was one of the questions I asked my manager, like, hey, what are we doing about positive cases? When are we initiating therapy? Who's deciding when is the right time to go in? Because these patients are going to need services, and they're most likely going to need rehab before they go home. And so right now, as it stands, the different departments are asking for PTs, OTs, and speech therapists to be the COVID volunteer team. So you can say no if you want. You do not have to treat a patient, but you can say yes, and then you're part of a specialized team that are just treating those patients. And so we're still basically in that stage where they're kind of, trying to see who would be interested in being on that team. One of the things I asked our manager that you actually brought up was about the chest PT to kind of save on respiratory therapy personnel and time and equipment. And actually they came back and they're like, that is a big thing we're talking about right now. And they're actually trying to find PTs who are specialized in that, who are comfortable with it and could train other people, other therapists in it, which I think is, if you look at acute rehab, take the spinal cord injury team and those PTs who do it all the time and are so good at it and train, other therapists in that. That's a big thing that they're going to be looking at for sure for those intubated, or those respiratory compromised patients.
Yeah. And that's what I was thinking too, especially with ventilator shortage. If we can at least work on positioning, do percussions, all of those things that we've learned for chest physiology that has, I think in the last 10 years, really been switched and early mobilization has just become the mainstay for acute care, which if we can do that, 100%. But we do have this skill set that I think is going to be extremely valuable to, you're right, ease some of the stress and strain on the nurses and respiratory therapists that are going to be so overwhelmed in the coming weeks. Mm-hmm.
Yeah. And so again, it's just another example of how it's just really a time to just share skill set and knowledge across every single type of therapist in every single setting. Like now's the time to share all of that information and all of our skills, and you know, help everyone who is on the front lines giving the care to be able to give them as much as humanly possible. For me, and I don't even look at it as a burden. I'm kind of like, put me in, coach, let's go. Like, I'm so ready.
Yeah, absolutely. And especially if we do have the PPE to keep our therapists safe.
Yeah.
I do think that, a lot of us are not the type of people that can sit on our hands. Like, just like you said, like, especially like ICE, we're very fitness forward, like all the types of things. So I feel like there are going to be a lot of clinicians, there are going to be a lot that are not going to be comfortable with that, depending on their own health, their family situations, etc. But I think you are going to have a big pool of PTs, like myself included, as long as obviously I can keep my daughter safe, that, again, I'm with you. I'm like, bring me in. You need home health? Absolutely.
Exactly.
Like, you have your acute care PTs who are overloaded, bring them home. I got it. I'll be in there every day.
Exactly.
And I think that, you know, having more of those discussions and trying to, band together as a strengthened unit is going to be so key, instead, because right now I think that the main feeling is panic and anxiety, rightfully so. We really don't know what's about to happen, but if we can band together and come from a position of strength and just, you know, do what we can with what we got, then, you know, we're in a better position for it, I think.
Yeah. Yeah. And again, it's like you're not sitting here thinking like, oh, I want things to get really bad. But at the same time, it's really cool from the standpoint of having some outpatient experience, having acute experience and rehab and all. It's to be able to know that now is the time that I can give all of that to these patients is awesome. You know, I mean, like the other day, I literally lifted the hospital bed up. I put the rails down and I did like a shoulder assessment on someone, like in the hospital, right? Because they're going home and they had a shoulder injury, and it's like, okay, I'm going to give them as much as I possibly can here, because they may not be able to get anything when they go.
Yeah.
And even telehealth and virtual visits. I know, again, like that's such a big topic in outpatient. Something that I've asked our leadership is like, look, if rehab liaisons can't get into the hospital, can we get on a virtual visit when therapy is with the patient and we can be talking to the rehab liaison? And so we can still advocate for a patient to go to rehab so that we can expedite that process. Yeah. And we're reducing risk of exposure, and virtual visits for family training, because again, I mean, in the hospitals, you're allowed one visitor and you have to be end of life pretty much, or in the ICU, which is devastating. And so when you're talking about us, these patients going home in a more acute state and we're trying to do family training and teach them how to transfer, we're going to have to utilize, you know, virtual visit telehealth to pretty much to do that teaching with them from home. So it's a very opportunistic time to
be innovative.
Yeah, be super creative and just expand, again, go from the scope of what acute care is. Acute care, we start the job, you know, and then we kind of defer to others to kind of finish the job. And we have to go from this to this. And it's going to be really hard, but it's going to be really awesome at the same time to be able to do.
Just show what we can do and help the people, because we do know that the majority of individuals are going to recover from this.
Yes.
And they're going to need help with that recovery. And I think, you're right. We're going to be great providers to be able to do that.
Yeah.
Cool. Awesome. So thank you so much, Julie, for coming on here and talking. I'm sure if I was to do this interview with you in another week, so many things would change.
Oh, yeah. Tomorrow.
I'll be asking you in a week to be doing this again. But I really appreciate you taking the time.
Yeah, thank you.
To our community and to ICE, and yeah, we'll talk to you soon.
We'll talk in like 30 minutes.
Yeah, we're going to talk in 30 minutes on Advanced Concepts call.
Yeah. Which I'm so pumped about.
Yeah, that's amazing.
I'm going to be right here.
Yeah, you're going to stay in the exact same spot. All right, thanks.
All right, bye.
Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.